So I'm Kate Hill from the compliance team, and Sherri, you know Sherri from Virginia Rural Health. We're going to talk to you about compliance. And the reason we're doing this together is about 2 years ago, Beth called me and said, I have a new hire. And she didn't come from rural, did you?
No.
Right. So would I train her so that she could offer a service of mock surveys to you folks around the state? So I've done that in about 4 or 5 states now. So it's been fun to do. And so this is her test. No, I'm only no pressure.
I'm not.
No pressure. We're going to do this together, okay? So let's talk about, so we're going to give you some updates. We're going to talk about common deficiencies and self-survey. So before we get into that, this came up already about what the secretary said about what's going to happen within 10 years, okay? Well, we hired a director of quality improvement, and you want to meet her. She is a fireball. She ran 11 clinics with our PCMH program in Missouri, of course, where they get really well paid to do that. And so we need to start getting ready for this. It's coming, whether we like it or not. We don't quite know what it looks like, but it's definitely coming, so we'll leave that. The public health emergency has been extended again, so now we're into July, and the secretary told us he would give us 60 days notice when it was going to end. We didn't get that for July, so we're figuring it's going to go to October. It very well may go, somebody mentioned earlier, it may be politically motivated. Yeah, well, what isn't? So we'll see if it goes to the end of the year or right up to Election Day or something, I don't know. But right now it is extended. What you need to understand about that is the day it ends, those waivers go away except for telehealth, and that you've got 151 extra days. But all the rest of them, if you have a different location, you don't have your NP in there 50% of the hours, all those things are done. So we need that 60 days so that we can get reorganized, regrouped again when the time comes. Okay, this is where, somebody just posted on the listserv, what's the link to the regulations? Well, Google 42 CFR 491, pick a number, 6. And it'll pop up, the government one will pop up, Cornell University will pop up. I happen to like that one because it's easier to navigate than the federal site, but they keep it updated beautifully and it's all there. That's the laws that you have to live by. It gets a little complicated when a person who had never set foot in a rural health clinic wrote a document called Appendix G. And that is her evaluation of what you should look for. And unfortunately, state surveyors use that document. That is not law. We like it when we like it, and we don't need it when we don't like it, I'll be honest, depending on what it says. But there are things in there that are not law, but boy, try to fight it. It's almost not worth your time. It's really a tough thing. But for what it's worth, that's how that happened. So we're going to talk about common deficiencies in mock survey. If you're going to stay compliant and all those other things, all the billing, all the codes, all all the things that Patty taught, all the quality, doesn't matter if you lose your number, right? So you have to stay in compliance, and you don't want to ever put that at risk. So I recommend that once a quarter is tough when you're this busy, but try to do mock surveys. Do your own. Put a process together and do the survey. Gather your team, get a checklist, get red pens ready, walk through the clinic, sit down and look at your policies. Are we doing what we say we're doing? And then at the end, have an exit conference, assign some things, and move on and be compliant. Because we're busy. We don't keep up to date, as none of us, including us. I mean, that's no different anywhere. Okay, so, and to celebrate it, because they've worked hard. You managers need to share your wisdom. If you don't happen to be there the day of survey, it can go sideways very quickly, very quickly. We don't know where to find it. We don't know what she means. So share that knowledge. As many eyes as possible on compliance makes it an easy job, right? Not just 1 or 2 people. And I highly recommend that, really. Okay, if you should move, please don't move unless you notify your state office. Call Beth, call the folks that do the HPSAs here. Make sure where you're going is in a HPSA. It could be next door and not be in a HPSA. You may be grandfathered in where you are and you didn't realize it. So lots of things can change. You must do an updated 855, of course, get that letter back. If you change your name, I can't tell you how big a problem this is. We pull up to a clinic and it doesn't match. And they never told anybody. That's a problem. What are you representing yourself out to the community? It's got to match what you've represented yourself to CMS. So make sure they match. Medical director is updated on a CMS 29. That is a reportable event. They need to know, and that goes to your state to know who your medical director is. That's our checklist. I think just about everybody in the room is using our checklist. So that's a good way to stay compliant. All the regs are there. Now, there are some things on ours. If you're, anybody state surveyed here still? You have some that are. Yeah, okay. So ours are different than we have added. That's what accreditation is. It's a step above, and you should be proud of yourself if you're accredited. Okay, so there you go. You can go from there.
So when a surveyor pulls up to the clinic, the first thing they're going to do is look at the sign. And as Kate said, the sign name must match CMS 855A. It must match. They're also going to check that the front door is clean, neat, accessible, safe. It's an opening for all types of people to be able to move into, and the hours of operation must be posted on the door. They're also going to look at the parking lot. It has to, I can't say it has to be perfect, but it needs to, not have a lot of chuck holes, not a lot of trash, loose gravel that someone could slip and fall on, so it needs to be safe as well. In the waiting room, it just needs, as same, be clean, safe, tidy. You don't want a lot of magazines laying around or things on the floor that anyone could trip on. If you have toys for children, they cannot be soft. They must be hard or plastic, wood, so that they can be disinfected. During COVID, in a waiting room, of course, we had to have the seats 6 feet apart, so that would be something that the surveyor would be looking for if we're still in that public health emergency. Once the surveyor goes to the exam rooms, they're looking for cleanliness. They're looking for no chemicals in the room unless it's a disinfectant. The disinfectant must have an expiration date on it. In the drawers and the cabinets, you shouldn't have anything. There should be no sharps, nothing that a child could put in their mouth, nothing that someone could steal, that they could harm themselves or someone else. The bathroom's the same way. It should be clean with a trash container and paper towels. In the exam room, if you have biohazard containers for the red bags, they should have a cover on them, so they want a lid. If you have a sharp container, it should be mounted on the wall, and it should be a one-way sharp container. It's locked, in other words, which I believe hasn't been a problem so far. If you have oxygen at the clinic, I believe you have to have one tank.
We require at least one tank.
One tank in the building. So if you have one that is empty and one that is full, you want them separate. So you want those clearly marked so that someone in an emergency doesn't pick up the wrong tank. Posters, you should have the current state and federal posters. There should be a provider disclosure. What am I forgetting? The HIPAA should be posted. And the civil rights, that's another one. The equipment, all equipment that's in your clinic, you should have on an inventory list. And that should be available to the surveyor if he or she asks for it. On that inventory list, you would have where the equipment is located, any kind of, you need inspections. The manufacturer will provide the information for doing preventive maintenance and so forth. If you have something that doesn't work or it's broke or you don't use it, just tag it. That way the surveyor can clearly see that this isn't something used or this is being repaired or whatever the circumstances are. Biomed inspection is evident with stickers, so you want to put any kind of labels on the equipment that's required by the manufacturer or by the state or federal licensing.
So let me just comment on that a little bit. We just had an issue with that. So when you look at a piece of equipment, it's the manufacturer's instructions for use that dictate, is it biomedically checked or is it just need a battery and a light bulb, like an ophthalmoscope? So you need to know that, because you don't spend money for biomedical engineering when you don't need to, but you need to know the difference, and that's only going to be by the manufacturer's instructions on the device. Oh, AEDs, battery checker, but the pads expire. Make note of that on your monthly checks. They do have a date on there. They do expire. So we don't want ones that won't stick should the time be needed. Yeah.
Also in your storage, you want to have a laundry type chemical storage room where you keep soiled linens or your cleaning supplies. Everything must be labeled. If it's, have an expiration date or a date that you mixed it, whatever the case may be, you want to keep that locked behind a locked door. That's another point I forgot. The lobby, the door to the back should always be locked. So, you have your lobby and then you have your door to go to the back rooms. That door should remain locked at all times. Also, if you have sharps, biohazard material, and medicine, all of those things should be locked up. Any supplies like that should be locked behind a door. Or the door should be locked, I should say. Fire safety, you need to have an evacuation plan, and that needs to be posted. Staff, of course, should be very familiar with it so that they can help any patient that might have a hard time moving around, or a younger patient that may have a hard time understanding how to get out. Fire extinguishers have to be tagged and easily found. They should be inspected. Usually it's once a year. Okay, I thought so. And you should have exit signs so that if you can't, we have these lighted exit signs above the doors here so that we know we can get out at any place. And then the HR files. The surveyor, I need to find that one, will be looking in all employees' files, and they will be looking for the application for that job that they are holding, their I-9 and W-4, an OIG exclusion, a signed job description, standards of conduct signature page, any kind of evaluations on their performance, any kind of training that they have, a competency, their background checks that you did when they were first hired, their TB screening, and a Hep B if they have that. Also, any licenses or certifications that they hold. These are the things a surveyor will look for.
Yeah, let me talk about this. This is our latest nightmare. For 2 years running, the largest deficiency is single-dose vials with a 28-day date on there. You can't make it up. I mean, to me, it's egregious, There's no preservative. There's no way to know in 3 days if it's a safe or effective medication. So that's a failed survey. We just had one that was the only deficiency, that one awful vial. And I'm going to tell you why that's failed survey. Because the first time that happened, it was actually pre-COVID. The surveyor called me. We have a 911 system when you're on site. And it was like 50 vials in the clinic. And this one lone single-dose vial had a 28-day date on it. And I said, you know what? Ask around, independent of other people, and find out what everybody thinks about that. And everybody was aghast, right? This is awful. And I said, okay, so they got it. This is human error. Write it as a standard level deficiency, and that means, because when I write it that way, then I get back proof of retraining, and that's what I wanted. We went through the clinic and we retrained everybody to make sure that wasn't going to happen again. 3 months later, I get a letter from CMS. They overturned my survey. That is a failed survey. That's unsafe medication. I know it's unsafe medication, but I guess there's no room for human error in something like that. I mean, it wasn't as egregious like cutting the wrong leg off. I mean, you know what I'm saying? But again, so we don't pass anybody with one single-dose vial. So if I can tell you anything, we've had MAs quite recently stand there and tell the surveyor she never knew there was a difference. Not a CNA, but an MA. How are they trained? Are you training them? Do you assume that 6-week course that they took taught them everything they need to know? I'm going to tell you it didn't, because that's where we're seeing it. Once in a while, we get a doctor who doesn't want to waste the money. What also has happened through COVID is large-size vials coming that are not single dose, and you would never even guess you get enough to anesthetize a horse in there if it's lidocaine, right? And it doesn't, it's single dose. Are they trying to make more money? Did they run out of little bottles? I don't know. But every nurse knows you pick up the vial, you look at the drug, you look at the dose, you look at the expiration date, and you look single dose. When we're taught to hold it up to the light to see if anything's floating in there that shouldn't be. So, I mean, that's not happening. And it's happening a little too regularly. So it's a small group here, and you're probably not the guilty ones, but it's a sin to fail a survey on that. And it's a shame to have that happen. We want safe medication practices. So promise me you'll go back and retrain, whether you think you need it or not, okay? And separate them. If you have a shelf, then make SDVs here and MDVs here. That works too, you know? The second most common is not dating the MDVs with a 28-day date. Once you open it, you've got to get a date on there. It's only good for 28. Okay, so, you know, find a way, but don't assume they know, because they don't. We had 15, it's June, we've had 15 failed surveys on single dose. That's way too many, way too many. Should be 1 or 2. And so really, please, go back and look. Single dose vials, never dated. Once the seal is broken with a needle, it's supposed to go. Now, you and I know we didn't draw anything up, and maybe the rest of that day we're good, but not beyond that. And you better hope the surveyor doesn't show up that day, because it'll be a problem. Now, if it didn't have a date on it, we wouldn't fail it. So it's a problem. So this is a clinic up in the Northwest. They had a problem with it before survey. It came up on the calls, actually, and they discovered it. So they put this little red bin in the med room. Only one nurse was allowed to put vials back in the closet. They were trying to track down their culprit, and they found him. And they retrained him, and they solved their problem. But they're going to do that on every once in a while basis to make sure we're still good, because it is very, very important. It's just one little piece of it. Pre-filled syringes are not acceptable unless they're pre-filled by the manufacturer in the glass syringes. There's no data that says pre-filled in a plastic syringe how long that's good for. And so that's a problem. I know it's an issue with flu clinics, and that's the last one I can think of was a flu clinic. And so they were, you know, they pull up, and 2 and 2 with lidocaine and whatever else they do, 1 and 1 or 2 and 2, which is the needles for the joints. You know, they do those a bunch. They know they're going to have a big ortho day or something like that. It's not acceptable, and it's going to happen on a survey day. It's going to be a problem. So because we don't have any data to know how long that medication is good. So that's not acceptable either. So this is from the CDC. It is acceptable to leave a needle inserted in the septum of the medication vial for is it acceptable? Excuse me. No. No. Now, those little glass syringes that come pre-filled, you can't put the needle on there. That's what that was about, and that was a specific instance. Controlled substances, you know you need a log, right? Every dose of that bottle, you should know where it went by patient name. Watch out for those in your samples. They do occur every once in a while. Sometimes in your emergency box, you've got controlled substances. You have to have a log to account for it. It has to be secured. It does not have to be double locked like in the hospital, but secured for sure. Sample medications need a log. Should there be a recall, we need to know which patient got which dose, which lot number of one of those drugs. Very rare to find an EMR that will pull it out by lot number. So you got to have a log sitting near the cabinet. This little guy on the right, that's from West Virginia. That's a great clinic. They had thousands of samples. And the time it takes for your staff to go through that closet once a month is a lot, right? And so you're standing there reading all those little dates. So they got 12 different colored stickers, and they sticker them going into the closet. So if this is June, whatever the last month was, you open that door, that color's gone. And you just pull them out. And it makes a lot of staff time available where they would just be. Pardon?
You still have to validate that particular specimen at the date.
Validate it.
Review the date. Even though it's been reviewed once, you got to do it at the time of use.
I'm not following you. We're talking about a sample medication that's expired. You just pull it out and you dispose of it properly.
No, I thought this was done in reverse, so you know not to pull it out. In other words, the different colors are there.
The colors are there to show what month they expire. Sorry if I wasn't clear on that. I'm sorry about that. Yeah, thanks. What month they expire. So if you open the closet and it's June and all the May colors are gone, and you didn't have to stay in there for 3 hours reading the little note. Sorry if I wasn't clear on that. Thanks for that. Appreciate that. Now, the CDC says we should not have medications in the door of the refrigerator. Okay? That's because it's not the right temperature as the body of the refrigerator. If you buy a fancy one like that middle one, do I have a laser pointer? No, I don't. Oh, gosh, what did I do? Never mind. There's no shelves in that door for that very reason. But we don't see those too often because they're very expensive. So put water bottles. If your state surveyed, label those water bottles not for consumption, not food. We've had that happen. And I had a state survey clinic call me, and I said, take her to the CDC website and show her. She said, no, it's food. They cited them. I felt so badly, but it's not food. That's not why we put it there. It's not for us to drink later. So if you have the state survey, I would label them just to be comfortable.
What is it there for?
Pardon?
What is it there for?
I'm not hearing you. I'm sorry.
What is it there for?
It's there to take up the dead air space. So the CDC says the door, there should be no medications in the door of the refrigerator. It's not the same temperature as the body. Under-counter refrigerators are acceptable if they're professional, but the ones that you buy at Target and Walmart to send your child to college are not acceptable. They're called dorm-style refrigerators. They do not maintain good temperature for medications, and that would be a citable event as well. So make sure you don't have that. Now, everything in the clinic that has a date is subject to the survey. Telfa, iodoform, gloves, all those things. So this was a survey I did in Kansas long ago. Oh, it's got to be close to 10 years. It was a 30-page report. I don't like it any more than they liked it, but I have to write it, and you have to write it 6 of 10 and 14 of 200, and you had to count all that and write it the way CMS wants it written. And so all that's expired. They didn't ever look at dates on anything except for medications. They kind of missed that lesson. That red can at the bottom is acceptable. It has a lid, it has a biohazard sticker. If it's red, it doesn't need the biohazard sticker, because that's why it's red. But it's not red, so it has a sticker. You do not have to have red bags in your clinic. That's for bloody, dripping dressings, so you don't need the cans. It's advisable to have 1 or 2 bags in the drawer and know how to dispose of it, but there's no requirement to have those bags. And that sharps container that's sitting back there in a patient care area is not acceptable. If it's in the med room and there's no patients ever left in there, it's fine, okay? Okay, so a couple years ago, well, actually it's 10 years ago now when we wrote our program, we wrote our emergency services plan to say that the medical director and the physician's assistants, NPs, will decide what's in the emergency box, because they live at that corner. They know what they needed, what they've needed for years, right, for the most part. And CMS actually adopted our program and got rid of that awful list. It took a while, that list of snake venom and all of it, antibiotics, all that, it's gone. But you do document in your policy how we came to choose those drugs. And it's a simple paragraph. And we made, yeah, Patty?
We have 2 worksheets that I'll be glad to give somebody. We have our 2 worksheets
On the emergency box? Good, good. Now your emergency box, if this is my clinic and that's the ED right there and there's a crash cart, I get this question all the time, do I have to have an emergency box? What's the answer? Yeah, because I am a rural health clinic and that is a rural health clinic requirement. Now I will say this, the decision to have 3 things in there is fine, absolutely fine. Maybe you have an EpiPen, maybe you have a baby aspirin, I don't know what else, but something else, that's absolutely fine. But you're 20 miles down the road and it's going to take a bit of time for 911 to get there, you got to have a robust emergency box. That's the decision you make, and it's a good decision. And it's in the policy so that the medical director or a physician signs off on it. We like a copy of it near the box so we can compare, okay, and that. Now, yesterday, big discussion, Monday, on our training. I was going to drive down here and listen to the whole training in the car. Those little zip ties with the numbers that you use on the emergency box. Who uses those? Why do you use them? Okay, so is that box locked in the medication room? Yes. Okay, and you still think you need that? I'm learning on this because I had a real different thought on that thing. If it's an emergency box locked in the emergency room, you just want to know so you replace the piece. So that's it's accountability. That's a good reason, okay. It's not an acceptable lock in the hallway, okay, and we see that as well. It's not. That box has to be locked. Now, the Urgent Care Association of America, when they accredit urgent cares, you are not allowed to lock your emergency box because it's about quickly get it and run. Don't find a key, to a room. So we are actually going to evaluate that. Now, it must be out of sight and reach, if you will, of a patient. So it could be in the nurse's station, unsecured, but in the nurse's station somewhere. But everybody knows where it is, except the patients, right, for the medications. So it's something we're evaluating right now, but right now all medications are locked, so we don't go away from that yet. But it's a thought. The box should be portable. We got to grab it and run. It's not all in a box, in a drawer. We're not going to take the drawer kind of thing, all right? It should be near the oxygen in the tubing. So we have this emergency process, and you will have a policy about what yours is, how you handle medical emergency in the clinic, and we grab it all and run, and somebody else is calling 911 as needed, okay? Any questions on that? We get a lot of questions on the emergency box. No? Good, okay. All right, so we were talking yesterday about Joint Commission's clean room and dirty room. Wonderful idea. We do not have that space in a lot of clinics. So that's great if you have that, but in your one workroom that most of us have, you'll have a clean area and a dirty or soiled area. And just make sure you have signage for that so that everybody knows. We never want to risk cross-contamination for anything, right? We want to have clean here, dirty here. You clean a piece of equipment, put it on clean. You don't do urine specimens and whatnot in the clean area, and you don't do medications in the dirty area, right? Just makes common sense. Was I supposed to give this back to you yet? No? Okay. We're working together here, and we didn't quite figure it out yet. We will. So sterilizing instruments in the clinic versus sterilizing them at your hospital. Who's doing it at the hospital? In the clinic? In the clinic? In the hospital? Here? Hospital. All right, so we'll take it in 2 steps. In the hospital, there needs to be a person in the clinic who knows what the process is. How do you know if it's right? Are they using event-related sterility? Should there be load logs in there? Are there little bars of ink that go black when it's sterile? All that. If you don't know what their process is, how do you know what to accept? You will have this deficiency, not the hospital. We're not evaluating the hospital. So make sure you know what it is. How you soak it, how you clean it, with gloves on, please. We've cited that just recently, cleaning dirty instruments barehanded. Again, an MA, we got to train. The process, how you transport them to the hospital, it's all very important, and then what you accept back. If you're sterilizing in the clinic, it says oh my for a reason. About 98% of the time, it's a deficiency when we see one of these. And here's what we do. We go in and we'll say, let's pull the manufacturer's instructions for that unit, because they're all different, and we'll read them together, and we'll compare it to your policy. And 98% of the time, they don't match. So are you handing your provider a sterile instrument when he needs one? You want to be 100% certain of that. No ifs, ands, or buts about it. It's as important as the medication to not have an infection, right? So make sure you know how yours is cleaned, how it's stored, how you know something's sterile when it comes out of there. Very, very important. Obviously, disposables is the easiest. It's also the most expensive, and so we don't see it too much. We see some. Never, ever, ever, ever is anything re-sterilized on that screen. Nothing. We have seen speculums in household dishwashers. I mean, you want to hear some stories? Yeah. I've got worse ones than that if you want to talk later. And I'll never tell you what state it was. It wasn't Virginia. The what? The rice cooker was probably the best. They were sterilizing instruments in a rice cooker. I don't know what the temperature of the rice cooker is, but it certainly isn't good enough. Now, the last picture, and then hopefully don't make dinner in it after that, right? The last picture is the forceps and the scissors for a suture removal kit. They are such great little pieces. People, I get it why you don't want to throw it away, but don't put it back in that container and represent it as sterile, because then you're going to have a problem. If you throw it in a drawer, nobody expects it's sterile, it's good. And we'll accept that 100%, not the other pieces. They don't go back in the drawer. Not the speculums, for sure. All right. Do we have anybody here from State Survey? I have to. You are. Hi. Nice to see you. Okay. So in the lab, you have 6 tests that you're required to perform, and get me the answer to the 6 tests today, right now in the clinic. Okay? For the hemoglobin hematocrit, it's the odd one because nobody orders it that way, but it is still required by the law. We are working feverishly to get that changed, both at RHA and NARC. I'm on both boards, so we're working on that. The one that we're seeing lately is the stool specimen. You're tending to give them the ones that they take home. That's not point of service testing. You can't tell if I'm bleeding today. okay? So you have to have the one where you drop the little reagent on the card. If you don't do it, fine, but the reagent has to be in date, the cards have to be in date, all those things, okay? So it's really very important to make sure that you have that. Your CLIA must be in date, not expired. It must match your address. These are CLIA wave tests still. It has to be accurate in the clinic. And all the strips and all that have to be in date. Some tests you do more than others. Back to Sherri's picture about the waiting room. One of the things we do when we're surveyors, after we introduce ourselves, by the way, photo ID and business card, and you should not let us in without it, okay? I have had clinics call to verify, even after that we have somebody standing there. Not a bad thing. You're not going to let people in. But then we sit down and wait while she runs in the back and says they're here, you know, or makes a phone call to a manager. We listen. And someone sitting at the desk calling out labs. Oh, Kate, we just wanted to call you and let you know your A1C is 14 or something, you know, and that's a HIPAA violation. So it's not that she can't do it there, but she can't do it when somebody can listen. So if there's no window, then you wouldn't do it when somebody's in the waiting room. The other thing, there might be papers there that she hasn't scanned in, so that just cover them. It's a simple thing. The biggest HIPAA violation we see is computer timeouts, where we walk into an exam room or we see sitting on a counter and there's somebody's PHI still sitting there. Quick timeouts, logouts are always best, okay? We don't get into passwords and social media, that's your IT job, but you should know what it would take to get fired. Every employee should know that, okay? So we had an incident with a young man, a high school football star, who didn't feel well, went to the clinic, and tested positive for COVID. The nurse in the clinic happened to know, because her kids go to the same school, right? It's rural, we know each other, said, he's having a big football party, a big party Friday night at his home. She posted on Facebook, do not go to John's party Friday night, he has COVID. HIPAA violation, anybody? Right. Now, as a mom, I get it. I get what she did, but I would have handled that about 1,000% differently than that. Right, yeah, exactly. Give me a phone call, something. I don't know if he had the party or not, but she's lucky that didn't turn into a huge incident. We heard about it. We didn't witness it, so we didn't have to go there. But sometimes it gets painful, for sure. Okay. 51% primarily primary care services. That's primary care medicine, OBGYN, and pediatrics. That's all that counts. We desperately want mental health to be counted in there. We're working on that. You're seeing it. It is part of your everyday, all day. So we're trying to get that change. We have not. That takes a law change because it's specifically called out in the Social Security Act that mental health is not part of that. So it's way back when that went into the law. We'd love to get that changed. Watch your specialists. Just make sure you don't go over the line. We want specialists in rural. You need specialists in rural, but it can't be more than 51% of your practice, okay? When the policies are developed, there's 3 people that sign off on the policies. An MD, an NP or PA, and an outside person. So that's a qualified person who is not in the employ of the clinic. Many of the provider-based clinics, it's the quality nurse at the hospital. That's 100% acceptable. Just make sure it's someone that's qualified. It does not, in the law, it does not say MD, although some states do that, but it doesn't say that anywhere. But qualified for sure, not the gardener or something like that. And we look for that page every time, and the date on it with the 3 signatures should never be more than 2 years old, okay? So that's an important little piece because it shows we reviewed our policies. So we just did policy review in March at the compliance team. And there were 3 policies where we were like shocked when we read it because we don't do it that way anymore. So it happens to all of us. And so you revise the policy, you get new signatures, and you move on, okay? And it's just something for everybody to do. Okay, 2 types of chart review. This is an interesting conversation that Patty and I had the other day after I spoke somewhere. Where was that? I don't remember. I don't even know what state I'm in half the time, or virtually anymore. There's the oversight of the physician of the charts for quality on did we treat the patient right? Do we do the job well? Do we provide the right prescribe the right medications? All of that. That's by an MD or DO only of the NPs and PAs to say that the care is proper in your clinic. The state here, 10% state. Are we a 10% state? We're no number. No number, okay. So it's very important that you pick a number. Put it in your policy, because how can the surveyor evaluate how many charts you reviewed if she doesn't know what's in your policy? That's really very important. So if you put 10%, then she's going to look for 10% charts to review, okay? The compliance team requires quality improvement chart review. So that's a different chart review. That's this. So these are the elements of what a complete file looks like. And we want that quarterly as well, because you need to know if you're doing things right or wrong. Are you missing signatures? Are you missing consents? Are you missing calls out to patients with abnormal labs? Some people take our chart and add on the end upcoding, undercoding, all those things. So we make sure we're doing that right. This is a trainable event. This does not need a physician. This is somebody that you've trained to look at a chart and make sure it's complete. Those are the elements that the government wants in our chart. So those are the two types of chart review. People get those confused pretty regularly. So the physician assistant and the nurse practitioner practice in accordance with your clinic policy. That's why they have to read them when they're hired. We want proof of that. We want signatures that they read the policies. How does this work? How does this clinic function? What's expected of me? And they participate with the patient in periodic review and sign that policy binder. And then the opposite is true, of course, of physician responsibilities, providing medical oversight, providing chart review, providing consultation care for patients, okay? Now your policies must include a description of the services that you furnish directly and that those that you refer. This is sort of, call it a mission statement. So we provide primary care medicine from birth to death, right? And we refer colonoscopies, mammograms, surgeries, orthopedics, whatever. So you're covered with that. It's a simple statement, but you don't want to miss that one. The guidelines for medical management of health problems used to be a book on everything known to man. Used to have one on hypertension and one on diabetes. Now we're accepting a reference that the medical director agrees to. So probably 90% of the time it's up to date, and Hippocrates for the rest of it. And that's what we hear. Who's up to date? Yeah. It's a good reference, and it's acceptable to the medical director. So put it in the policy, because he's going to sign off on that policy. So we're not going to go to Kate's Primary Medicine, which nobody would read, right? We're going to go to up to date, and that's acceptable. For if you want to look something up, we want to make sure the reference is accurate for sure. The maintenance of healthcare records for the provider base is typically at the hospital. That's somebody that's in charge of that. Lately, it seems to be it's IT all the time, the people that are in charge of your records. And rules for storage, the rules for storage, handling, and administration of drugs and biologicals is your most robust policy, maybe next to infection prevention at this point. But that's a big policy with lots of elements. How we handle medications, how we handle vials, how we handle medications in a power outage, who can give medications, what's our process? And so it's a big policy. Look at our checklist, and you can see all the elements that should be in that policy. And again, these policies are reviewed at least every 2 years by the three people. The outside person, the medical director, and the,
Kate,
yeah,
can I ask a question?
please.
So on the second bullet, on that last one, it
Yeah.
used to be we needed to have policies for the specific.
Correct, we do not.
So we don't. We
Not.
can rid of those policies and just have a statement that we will see.
Correct. Correct. Are you good with that? She said she used to have a policy for hypertension and diabetes and all that, no longer.
No, or if you incorporate it into your policy based off of the population, your patient population, that's really what we would be looking for.
I would look for that, yeah, exactly, excellent. So if there's something unusual in your clinic that you're treating, I might want to have a special policy, but normally no. It's the place to go look it up. Yeah, you don't need all those anymore. That's a nice change, good, I'm glad you caught that, good. Okay, one NP or PA must be an employee of the clinic. You can have all the rest contractors, but one must be an employee. That's still with us, and so till it goes away, we have to look for that W-2. And then an NP, PA, midwife, clinical social worker, clinical psychologist must be in the clinic at all times the clinic operates. That's to see patients. They can be in the waiting room out of the weather, but you cannot take them in the back and do blood pressures and weight checks and draw blood before they're on their way to work. We understand that that's kind of an old, what is an old law. I go to Quest for blood work. There's no doctor anywhere to be found. There never will be. It's a bunch of techs. I hope they have CPR. I don't even know that, but it would be nice if they did. So it's because of rural rural in 1977 was more rural than it is now. Yes, we have real rural, and we actually still have some frontier clinics, which is population 6 per square mile. That's pretty rural. Out west, I don't think we have any of those in the east. And so they are still there, and I get it, and they should adapt to that more than the rest of us. But at any rate, we have to live with that rule. It's very hard. I'm the provider, I'm calling, hey, I'm 5 minutes out, load up the rooms. Nope, nope. Could an incident happen in the waiting room? Yep. So you deal with it, you know, but it is the rule, and that's CMS interpretation. I've actually talked to CMS about this. There's no give on that one, okay? And then 50% of the time the RHC operates, the NP or PA must be available for patients. The admin time counts, but you must document it. If we don't see it anywhere, then it didn't happen. Who said earlier, if it isn't written down, it didn't happen? That rule applies. Nursing home patients account, but again, document it. So you're counting your hours when you're on the edge, and you've got a clinic that's 40 hours and she's there only 20, you're on the edge, and we're going to look every time and verify, okay? I want to go back to something just dawned on me, what we look at every time. On the HR file, we look at every licensed person in your clinic, we're going to verify the license. We do not necessarily look at every HR file. We'll do a random selection, minimum 10. And then we'll go from there. If there's an issue, we'll keep going, you know, that kind of thing. But we don't need to look at everyone. We see the patterns. Those of you who are provider-based are fortunate to have HR departments. It's really tough on the independents. Have those files secured in your clinic when you're an independent clinic. Are there any independents here at all? Oh, you have one, yeah. But they can be there, but they need to be secured. We don't have them laying around loose all over the place, because that's confidential information.
Kate, I have a question about that too. So all these travel providers we have now, or temporary staff because of COVID, all of those HR, and I'm not talking about licenses, but all of the other HR audit information we need to have for them, their I-9s, their BLS.
Traveling staff, so they're employed on a temporary basis. What do you think about that? You need it? Oh, you got to know who they are for sure, right? That's a,
We have their license and certifications, but
It doesn't matter how long they work there.
yeah,
Employee, you gotta have.
yeah. Even a temporary,
I hate
yeah,
it, but that's,
that's what we do, but I was
yeah,
hoping to
can't get out of that.
yeah. I haven't run into that.
If we did that, you know what we would have? We would now have clinics that only have people working part-time, so they don't have to keep up with all the paperwork. And
Yeah. By the way, there are no locum NP or PAs in a rural health clinic. There are only locum MDs, and I've seen that on the listserv. That is not correct. It's right in the regulation. There is no locum NP or PA. Okay? So just bear that in mind.
speaking on HR, I didn't see you cover, are you gonna cover the COVID vaccine?
Yeah, that's, yes. Yes. Yes, Jeffrey, I am. And then the other thing is, of course, your policy is reviewed every 2 years, okay? So we do a biennial evaluation. Why do we do this? Well, we're going to make sure number one, we're living by our policies. That was one of the ones I was actually disappointed when it went to 2 years, because who doesn't look at their business every year? We got to look at it and make sure, are we doing the right things? Are our services right for our community? Do we need to add some, lose some? Are our policies up to date? My husband and I do it at home. He drags it out the first week of January every year. Well, we didn't save enough and we spent too much. That's the same story for 36 years. You know, what can I tell you? We're not learning, but at any rate, we are getting better now because we're getting near the end. But at any rate, so it's really very important. So it is biennial. That doesn't mean that at 2 years you don't need 2 years of data. So gather it up that first year, throw it in a file, and then make a big report at the end of 2. Do not miss that. That was not waived during COVID, and we had a couple issues with that where they just didn't do it. They thought, oh, that was waived. No, there was no waiver for biennial evaluation, so you must do that. Go back and look. Make sure you're in compliance right now, that your biennial is not more than 2 years old. And if it is, get it done quickly, just in case somebody shows up. All right? And then what do you do with that information? It's sort of like an after-action report. Well, we evaluate it. We write up a paragraph. Here's what we learned. Here's what we found. We found 10% of our consents are never getting scanned into the computer. And we find that. Ironically, you look at 10 patients and you find one with a consent missing. It's not that it didn't happen. It never enters the file. And they got to search for it all day in boxes of consents that they saved before they shred. Okay? So make sure you're doing that. All right. Emergency preparedness. And we have a new memo on this just recently. So there was some guidance. It's already over a year old. I can't believe I probably should take this out, but it seems new to people on what happened with EID. So we need EID as one of our risks. Our risk assessment will include emerging infectious diseases. Make sure you have that in there, and then what you've done about it, what you would do about it. You already have that, and you've lived it for 2.5 years, so you would have there. Your plan obviously must be in writing. You must choose your exercise, not event, but your exercise from your risk assessment. So I'm in Pennsylvania, we don't have tornadoes, so my clinic's going to do a tornado drill. That's great. It's not going to count. If the surveyor has read this, it's not going to count, because why would I do that? Why am I preparing for something where the likelihood is very small, right? So you want to prepare for things that are on your list. By the way, back to the fire things, fire safety, fire drills once a year. Please be doing them. That's how we know that you've trained. We ask, you know, what's your process? How do you get out of the building? Who checks the rooms? Where do you do a staff count outside? Who was here today? All those kinds of things. So you have a, you know, it's muscle memory. When there's a fire, it's not the time to figure all that out. The testing. Okay, I already said that one. Right. Volunteers. When this came out, I called CMS and I said, okay, we don't see volunteers in rural health clinics. She said, yeah, I know. It came over from the hospital side. Oh, yeah, right. So what are we going to do about it? Think of the checklist that I showed you earlier with all the little boxes that the surveyor, whether state or us, has to complete. And there's that line, volunteers, and you didn't address it. Then it's going to be a deficiency. All you need to do, and I'll be curious to see, I haven't had a state that said no to this, is write a statement in your policy. We have made the decision not to utilize volunteers. Will you accept that? Yes, wonderful, thanks. And so now, if you want volunteers, you're going to name them, HIPAA train them, and emergency preparedness train them, all right? But we understand that we just had a terrible incident in Idaho in a clinic. The volunteer was the person sitting in the waiting room, and he stepped up to help the receptionist against an unruly patient. He wound up with a broken nose, but he was the volunteer because he could help her. And you know, when they happen, you're not going to call your volunteer up, you know, kind of thing. So it's who's there and able to help. So just remember that. Okay. Waivers. In the new guidance, it says verify how you're going to manage your waivers. I guess you would verify that based on what we have this time, because it would probably be different. Now, it went to one full-scale exercise or event every other year, all right? So the in-between years, you can do a tabletop, or if you have another event, of course. We hope we don't have one. Let's hope we don't get a break and do a tabletop this year. I'm going to talk more about the latest guidance that came 3 days ago at the end here. I've got a new slide on. Oh, this is it. It's, you know about QSOG memos, used to be called Survey and Cert, now it's QSOG. So this memo came out this week, 20-41, or last week. Yeah, last week. Now, so this was what was happening, I think, is that nobody expected it to last this long. So people were just writing that event. It started in 2020, and it's still rolling into 2022, not acceptable. An event is 1 calendar year, and that's what this is all about. So you ended it, whatever your date was in 20, let's say it was March, just because that's what in my mind for it starting. March 20 to March 2021 was COVID-19 event. And you wrote it up, and it was, oh my gosh, we don't have hand sanitizers, we don't have masks, we got to do telehealth, we got to close the waiting room, we got to have them call from the car. All those things when we didn't know what we were really dealing with, right? If you go from March 21 to March 21 to March 22, it's a different story. It's vaccinations, it's testing, it's a whole different, it's vaccine hesitancy in our community. It's all those things. And that is acceptable to write up, but they're two different reports. Do not let them go together. That's what this is all about, okay? So make sure you're analyzing each and doing your review, okay? You are exempt from the next full exercise in, depending on when you wrote, like 20 would get you exempt in 22, but we're still in it. So it got a little muddy, but you are exempt from the next full-scale exercise or event when it comes, all right? Additionally, while facilities may be continuing to operate, that's where this got sticky. You're still operating under an emergency plan, right? We encourage facilities to consider conducting their individual-based exercises if possible. It's still only required for 1 a year, all right? So if possible is with that. That's an encouragement. Okay, I think I talked about all this already. But the point here is exemptions do not accumulate or carry over to following full-scale exercises. It would not carry over because the facility was faced with 2 separate emergencies. So you got to make them separate. Is that clear? This is brand new last week. Okay. So for every event, exercise, or tabletop, we're writing an after-action report or hot wash, if you will, depending on what you call yours. But it's an analysis of what happened. The government has this wonderful list of things. The form is wonky, but if you Google CMS AAR, After Action Report, this is what will come up. And it gives you all the elements that should be in a report. You do not need to use this form. You need to have a report. And this is just a brief one from 2020. Patty had a lot to do with this. We keep adding to it, changing it. This event occurred in 2020 as a result of the virus, which resulted in a worldwide pandemic. It began for our clinic on what date? Now, depending on which year you're using this for, don't use 2020 if you're writing for 22, right? And then who's our team? Our governor declared an emergency on this date. Is Divine your governor, or is that from another state? That's what? It's not, oh, I know him. He's a good guy. Okay. The report is a follow-up analysis of the COVID event, which happened whatever year you're choosing. That's what's important here. And then you start rolling in what were our strengths? What did we do well? What did we need to improve? What were our successes, and celebrate them? I mean, the way telehealth took off, you thought we were doing it forever. And then what staff training? All training, all training needs a training log. Because again, if it didn't get written down, we don't know what happened. One, signatures of the staff, date at the top, and what was discussed on that training event, okay? Okay, the newest law that got slipped in there last year, 491-8, is COVID vaccinations. Let me just tell you that we had a clinic recently that didn't pass on this part of it, and they were 100% vaccinated, 100%. Why didn't they pass? They thought since everybody's vaccinated, we didn't need any policies. Wrong. The policies are written in the law, and you have to have the policies. So make sure you look at that list of what's required. All right? So you have to have the policies. Now, what does 100% mean? 100% means vaccinated, medical exemption, or religious exemption. Medical exemption is by CDC guidelines. Religious exemption is by your policy. What does it say? What do you accept? We will never question a religious exemption, but we're going to look at your policy. So how is it laid out? What does it look like? Okay? We're not going to question, it's not our place. I have a hard time questioning medical because it's written by an MD and I'm not one, right? I'm a nurse. So but there are CDC guidelines for what is acceptable medical exemption. Question? I'm not hearing, sorry, even with the hearing aids in.
Anything that might come out for boosters.
Boosters, okay.
Requiring either an exemption or anything.
Right. So boosters, it's required to be tracked. You do not, unless it's a state requirement, you do not have to be boosted. But you must track every boosted patient, staff member. So you have a log, and you have vaccinated, and you have religious exemption, and you have medical exemption, and you have boosted. And the next column is on hold. What am I on hold for? And that's right in the law. We're on hold for, maybe I'm 8 months pregnant and I'm not about to get it right now. Maybe I just had monoclonal antibodies and there's a time waiting period. Whatever the reason is, there's a hold category that you must track to verify that we're off hold now, let's get vaccinated. You cannot hire anybody now that's not vaccinated in any state in the nation, in medical, in any state in the nation. Okay? Cannot. Okay. So, and who are the employees? So there was a survey recently in a state, not Virginia, a hospital survey, where there was large construction going on in the parking lot, okay? And the survey team was on site, and they went to the lunchroom, and in comes all these guys. And they're dressed like construction workers, of course. Everybody knew they weren't hospital people. And so the surveyor went over and asked to speak to the manager of the team and asked to see the vaccination cards. They were not vaccinated. They failed the survey because they came in the building, in the cafeteria, in the restrooms of the hospital. Watch out who's coming in your building, right? And so the regulation reads, assess. Is it the cleaning people and they only come at 8 o'clock at night? I could care less then, right? But is the drug rep coming in, going in the back, interacting with you and your staff and your patients possibly? Are you requiring vaccination there? Every surveyor, we have to be. I'm sure state has to be as well. Yeah, we can't work if we're not vaccinated. Now we fortunately didn't have to deal with a religious or medical, but everybody's vaccinated, so we're good. We had one holdout for a long time, and then it came down to her job. She had no medical, she just didn't want it. And so, well, you have a choice. You can work here as a surveyor or you're not, because we can't go out unless we're surveyed. But you watch who's coming in your building. So I can't make that decision for you. You have to, have good decision making on how you're going to decide who those people are that are coming. If they're coming in regularly, you're going to have them vaccinated, and you're going to have to see proof. We see every vaccinated. We don't look at every HR file, but we look at every license and every vaccination proof. Sometimes it's a state log if you went through one of the state agencies. Sometimes it's a card. It's all looking a little different. Try to make it as easy as you can for the surveyors to show that proof so that you're not hunting all over the place for it. But it's definitely necessary. So obviously, let me tell you how big a deal it is. We report weekly, every Friday. We report on the vaccination rate at the clinics to CMS. And don't be late, because Scott will be on the phone Monday morning. Why didn't you send it? Okay? So it's a big deal to CMS, a big deal. So we don't like it any more than you do. It's more work, more paperwork, more tracking and stuff. It's required. So we have to live with it now. It's in the law. And the only way it's coming out of that law is a law change. And we all know how hard that is to get, right? No, it's in the law, right. It would only go away if there's a law change. Like we would love to get the 6 labs out of the law. We would love you to have the labs that you want in your clinic. But the hemoglobin hematocrit, who needs that? We do CBCs, but we're having a tough time changing that. There's somebody on that committee in Washington, this came up already, that thinks that's still necessary, that we do those 6 labs. So we haven't won that one yet, maybe we will. But it'd be nice if you could have the labs that you think you need, or do them at the hospital. You're right in the building, that kind of thing. So whatever. All those things are yet to be decided. Okay. I wanted to get to policies. The other most important one is that you have a written process to protect the people that are religious or medically exempt. How are you protecting them in your clinic from sick patients? What's your process say? We're going to read that policy. That's an important policy. The other one that kind of slipped in here is 3I, a process for ensuring that the clinic follows nationally recognized infection prevention and control guidelines to mitigate the transmission and spread of COVID-19. There was none of that infection prevention in the standard, in 491 1 through 12 before. We had it in our standards, and people look for it, of course. It's written now. We're looking for that. What are you following? And again, you're doing it, but now you need a policy to prove it on how you're preventing the spread of infection in your clinic. So it got pretty bad. So the process for tracking the staff, the process for the vaccination staff of the boosted, right? A process that those that requested an exemption, whether medical or exemption, and then a process for securely tracking and securely documenting information provided by those staff who have requested or been granted an exemption. So we're tracking just about everything we could track on this thing, for sure. I think I covered all this. Contraindications are CDC ones. And you can't sign for yourself. I know why they put that in the law, but the doctor cannot sign his own exemption, period. Okay? Not allowed. Oh, and by the way, NPs and PAs can sign medical exemptions. That's allowed. It says provider, does not say NP or PA or MD, okay? The statement must be clear about why they can't medically get the vaccination in the write-up, all right, before the signature. And the last one is the contingency plans, for sure. Okay, all right. So you have, in your mock survey for EP, you have your hazard assessments, including EID, and you have a plan for each one. So if you've chosen 6 things that are common in your neighborhood, and get those from your state website, because they know exactly what's happened every time in the state of Virginia, right? And then your 6 over here, okay? Communication plan. People say, well, we've got everybody's phone number on our phones. Yeah, I get that. The law says you're going to have it in that policy, so please type it up, put it in there. And then I get, well, we have turnover. It's a pain to keep it up. I don't think any surveyor is going to match that list with who's still working here. If you have you want to get the new people in there, that's the way to check it. But please keep it up to date as best you can. Must address the volunteers. You also must address how refrigerated medications are handled in a power outage. It's 9 o'clock Friday night, you're all home with families, the power goes out. Maybe you live 20 miles away, your power's just fine. And the power's out till Sunday afternoon. And you come back to work Monday, and those temperature minders are all in range. How do you know those drugs are safe? You need to answer that question. Are you generated? Do you have a data minder? Somebody got a text and said, uh-oh, go move those drugs. You need to know they're safe on Monday for safe medication administration. So have that policy. It should be actually in your medication policy and then copy it over into your emergency preparedness policy, okay? And then a training log, training every 2 years unless something significantly updated, and I would fully expect a lot got updated this year in this subject, right? And list of people, everybody in the clinic, and a date, and what we discussed. So, can your staff articulate what they're responsible for? Do they know where to go find something that they're not really tuned to every day? If you're not there for date of survey, very important. What does it take to get fired around here? Everybody should answer that, know something. The NP should say, well, I guess if I passed out scripts to people that weren't patients, I'd get fired, yeah. If I had, we had one that had 10 opioid prescriptions signed by an MD who was not in the clinic, so the NP could give those out as needed. That was a reportable event to DEA, that just wasn't a failed survey. But that certainly could get you fired. How do you evacuate the clinic? That's important, whether there's a fire, an incident. So Sherri mentioned that door to be locked. That is not a regulatory piece. We are very clear about that. That's 1 degree of separation from the disturbance in the waiting room to a disturbance in the back, okay? Where is the disturbance? Let's get the people out the front door or back door, vice versa, should there be an issue. There are issues, we hear of them, okay? There are many issues. We just had a surgeon shot by a patient in pain. So what's to say that couldn't have happened in a clinic? So all these things you need to be wary of. I mean, you know what's going on in the country with the guns and all that. So we don't want to be a victim of any of that. We want to try and keep everybody as safe and secure as possible. The other one that was highlighted on the listserv this week was plug covers. So that is a safety precautions. Kids don't want to stick a fork in there, right? But most of if you have a new building, you have the slider ones that you don't have to worry about that. If you have the old ones, you probably should have them covered. We're probably not going to cite that we're going to teach on that one. We used to cite it, but it turns out that the cleaning people kept taking them out to put the vacuum in, and then we'd have to write it again, and we got tired of writing it. So we teach on that one. That's a good one. It's not really in the rules. Okay, and then know where to find stuff. I already got that. Okay, surveys are all unannounced. We are required to be in your clinic at a minimum of 6 hours. Some days that's a stretch for a 2-room clinic. But if you're really looking at things, you are looking at things. Most surveys take a full day. And if it's a 40-room clinic, it's going to take 2 days, okay? We're going to do a grand tour of the place. We're on a big 40-room clinic. We're going to make notes on our way around. Oh, I want to go back in room 6, room 8, room 10. We'll look at about 25, 30% of the rooms unless we see something, and then we'll go further. We probably won't look in every room on a 40-room clinic. Some of them are getting quite large. You have to wonder if it's rural. And then at the end of the day, we'll have an exit conference. You should know exactly what went on that day. Okay, there are times when the surveyor does not make the decision whether it's standard level or condition level because it's a manner and number and we have all these expired things and you're just not sure, and she will usually tell you that. So because we have 3-level review, every statement of deficiencies is reviewed by 3 different people, and we have a lot of interesting discussions on what we see in those things. So we want to make sure we're doing it accurately and consistently the same every time based on what's in the standards. Okay, for sure. And then you get if there's no deficiencies, we're reporting to CMS a day later that you did well and you're on your way. And if there are deficiencies, we send that out, a statement of deficiencies. You write a plan of correction. The date the plan of correction is accepted is the day you're reaccredited or accredited for the first time. There are unacceptable plans of correction because you didn't document how did this come to be. What are we doing to fix it? And really, most importantly, how are we going to keep it fixed? So like everything else with quality improvement, you've got to figure out, what's the best way to keep this from happening again? Because we could come back in 3 years and find the same thing. And that's not what we want to do, right? and I'm probably too long. Questions? Do we get them all as we?
19 policy which they have changed because, that policy itself is controversial because even the Court of Appeals are still discussing about the vaccine, whether it should be mandatory or not.
Right.
So how can they ask the rural health clinics to follow the policy which is controversial policy?
Right.
So in that case, if my employee says that, well, this is still a debatable issue, and why are you forcing us to do this, then what answer should be given to them?
It was written into the law for rural health clinics. They literally made it law.
But still it's a controversial.
Well, and it may, yeah.
The appeals of court are
If-
saying that this is a controversial.
If we don't pass you because of that, or you have a deficiency with one person, you would still pass. You would have to show that you're going to correct that. And if you don't correct that by him not working there, no, I'm just saying.
Currently, but what I'm saying is, one of our employees had asked us,
Right.
if you are telling us to,
Right.
take this vaccination, then it's not a proven thing, and the courts of appeal has not decided, how can you force us?
It's a challenge, but
We told them that this is the rural health clinic, they have just made a law, and nothing we can do about it.
so on this, you have something? Go ahead.
Well, I would say because you're a federally certified
Right.
rural health clinic by CMS, that's what CMS says is based on the requirement.
Yeah, that's what we told the employees.
Right. He makes a point. There might be a lawsuit there, but yeah.
Actually, still it's a controversial issue, but,
Yeah. We don't make the rules, yeah. No, I understand his point.
I would answer it this way, here's what we did.
Yeah.
If an employee finds it conscionably objectionable to comply with the law that's questionable and intends to sue otherwise, and it's a matter of their conscience, they should request a religious exemption.
That's up to your policy. I'm not going to go down that road. So let me just use another example of something like that. So I was on the phone a couple weeks ago with a young man, a nurse practitioner in the state of Washington. The state of Washington has 100% autonomy for their nurse practitioners, as probably half the states do now, right? They don't need medical oversight. That's the law in the state. And he didn't realize that until he got well into the program. Shame on him. And I said, no, you will have a medical director. He said, no, I won't. I'm not listening to any doctors. Arrogant young man that he was. And so I said, well, you're never going to pass survey. I'm so sorry. You're coming into a federal program and you have to have oversight. I get that you don't like it, but you will have one. Now do a minimum chart review. Just do minimum. Your state's good with that, but you still have to do it. You still have to hire him. He still has to oversee your clinic. It is the law, and it's the same thing of the vaccines. It just is what it is. Yeah, Patty?
I was gonna say, that is something I deal with multiple times a week. The medical director role for an RHC is a completely different role than the collaborative or the supervising physician role.
Yes.
So people are always confused.
He does not have to have a collaborative physician or a collaborative
Right.
agreement. Right.
So-
But he has to have a medical director.
So even if your state's like Washington, like you said, you still have to have a medical director. That's still in 491.8, and it's in 491.4 too, I think.
Not four.
But it's different roles, and it has nothing to do with state stuff. Yeah, I agree, but that happens all the time.
Yeah, okay.
And the COVID vaccine mandate is for all certified CMS facility types, just not RHCs. So it's not that they singled us out, it's every certified
Yes.
program.
So the major challenge we're having right now, I'll be honest, and I'd love to hear, I don't even know your name. What is Emily. Emily, I'd love to hear Emily's opinion. So we get this question like 4 times a week right now. Do we have to mask in the clinic? Well, I have searched on CDC, and it's gray. If your hospital, and the hospitals still do have to be masked, right? Yeah. So if you're a provider-based clinic to a hospital and they want you to be masked, you're going to be masked. If you're independent, here's what we do. If we walk into your independent clinic and you're masked, we mask. If you're not masked, we take them down. We're all vaccinated. So where do you sit on that, Emily?
Well, we would go to the CDC website for further guidance, which, like you said, is gray. So
Yeah.
But you're right, if it's a hospital provider system,
It's hospital,
then
right,
it's
it only
required,
says
yes.
And each state, certain states have that match.
Well, if it's state, that's different. If the state mandates it, you're done. You got to do it, yeah. Yeah.
Does your contingency plan not matter in how you're accommodating those?
Well, it depends on how you've decided you're going to take care of those people, yeah. Is masking going to do it? Maybe when they're with patients, they're masked? It might be, it might be. It would depend on their policy.
If we've had 2 live emergency event plans in 1 calendar year, do we still need to do the tabletop?
If you've had, no, you've had 2 year, for 1 year and another year. 2 in 1 year. Well, you're good. No, the next year you still have to do something, a tabletop or something. Yeah, yep, yep. Something every year. Something every year, yeah.
That's the easiest way to do it. An event lasts 12 months.
Right. This one's lasting 2.5 years, but that doesn't count. You got to write it. Yeah, so do a tabletop.
12 months, I guess is my question.
Well, it's going to be date. Whatever date you're writing that report is your date.
One in March and another one in May. It's 12 months from May?
Right.
Yeah.
Okay.
Your year, everybody's year is different on that one, yeah. Thank you very much.